Imagine stepping up to a patient's hospital bed on your very first day of clinical rounds. You don't have an MRI machine humming in the background.
Right.
You don't have a high-resolution CT scan loaded on your tablet, and the lab results are, well, they're hours away from coming back.
It's just you.
Exactly. Just you, a stethoscope in your own two hands. And your task is to map the unseen, incredibly complex physical landscape of a failing lung hidden behind this thick wall of bone and muscle.
It is the absolute definition of diagnostic muddy waters. And frankly, it's the exact scenario every junior doctor finds themselves in at 3 a.m.
Oh, absolutely.
In modern medicine, we've become so accustomed to visual confirmation. We expect a digital screen to just highlight the broken part in red.
Like a check engine light.
Right. But without that imaging, you are essentially drawing a highly detailed topographical map of a completely dark cave, using nothing but the echoes of your own tapping and the sounds of moving air.
Which is exactly why we are turning the lights on today. Welcome to the Deep Dive. For this session, we are analyzing a massive, exhaustive masterclass clinical lecture and translating it into an immersive audio experience for you.
Yeah, we really are.
Our source material is this authentic mentorship-style lecture, originally delivered in Egyptian Arabic by a seasoned medical educator, Dr. Mahmoud Alam. And he's speaking directly to a room full of medical residents.
And our mission today is to act as your clinical guides. We're going to distill this data-driven lecture into practical bedside takeaways.
So if you are a medical resident or an intern listening to this, consider this your ultimate grand rounds.
Exactly. We are not just giving you a list of textbook flashcards to memorize. We are decoding the physics, the fluid dynamics, and the precise mechanical failures of the respiratory system so you can make immediate, accurate, life-saving decisions on your very next rotation.
So let's establish the geography first.
Yeah.
Because, before a detective can solve a crime inside a house, they have to know the exact architectural blueprint of the building.
You have to map the surface anatomy of the chest. It's about creating a GPS grid on the skin that corresponds perfectly to the organs underneath.
Right. And that geographical map relies on a very rigid numerical rule for the borders of the lungs. The rule of 6, 8, and 10.
Yes, the 6, 8, 10 rule. So if you trace down the front of the patient's chest along the mid-clavicular line, meaning right down the middle of the collarbone, the lowest functioning border of the lung tissue ends exactly at the 6th rib.
And as you move around the curvature of the chest to the side of the body, along the mid-axillary line, dropping straight down from the center of the armpit, the lung tissue extends further down, reaching the 8th rib.
Correct.
Finally, if you go to the midline on the patient's back, right along the spine, the lung drops all the way to the 10th rib. So it's this downward sloping plane, right? 6, 8, 10.
But you also have to account for the pleura.
Oh, the fluid sac.
Right. The double-layered, fluid-filled sac that actually houses the lungs and attaches them to the chest wall. The pleural cavity naturally extends exactly 2 ribs lower than the lung tissue all the way around,
creating a reserve pocket.
Exactly. So the pleural borders follow a rule of 8, 10, and 12.
Which is such a critical distinction for a resident holding a needle. Like, if you need to drain a pleural effusion, a buildup of fluid, you have to aim for that anatomical gap between the bottom of the lung and the bottom of the pleura.
You have to, because if you miscalculate and go too high, you puncture the lung parenchyma itself and cause a pneumothorax.
And you definitely don't want to cause a collapsed lung while trying to help. But what I find fascinating is that this blueprint isn't perfectly symmetrical.
Not at all.
We always picture the lungs as these identical mirror images, but the right lung has 3 distinct lobes separated by 2 fissures, while the left lung only has 2 lobes and a single fissure.
It is entirely asymmetrical, and that is driven by the real estate demands of the cardiovascular system. I mean, the left lung literally steps aside. It structurally concedes space to make room for the heart.
And that architectural concession creates a feature on the left lung called the cardiac notch.
Right.
And functionally, that notch creates what the lecturer calls the bare area of the heart. The notes say this occurs exactly at the 4th and 5th intercostal spaces on the left side.
Yes. Because the spongy lung tissue pulls completely back at this specific coordinate, the cardiac muscle is directly exposed to the interior of the chest wall.
which turns those specific coordinates into a highly sensitive acoustic window.
Exactly. So if you are examining a healthy patient and you percuss or tap on that fourth or fifth intercostal space on the left, you will not hear the hollow resonance of a lung.
You hear the heart.
You hear the solid, dull thud of the heart. If you tap that area and suddenly hear a hollow, drum-like resonance, you instantly know the internal architecture has catastrophically shifted.
Wow. Meaning the lungs have hyperinflated and crushed that space.
Precisely. So once we have the anatomical grid locked in, we have to look at what the patient is actually experiencing. And in respiratory medicine, that always comes down to the diagnostic tetrad.
The big four.
The big four. Cough, expectoration of sputum, dyspnea, which is shortness of breath, and wheezing.
As a junior doctor, it's so tempting to hear those four symptoms and immediately think you have the whole picture.
But having the symptoms is only half the clinical picture. The actual diagnosis is hidden in the timeline of those four symptoms.
Right, because if a patient comes into the clinic and says they have had a daily cough, daily sputum, daily wheezing, and progressive shortness of breath every single day for the last 5 years, you aren't thinking about a reactive airway issue.
No. The constant, unrelenting presence of those symptoms indicates irreversible structural degradation. That timeline points overwhelmingly to chronic obstructive pulmonary disease, or COPD.
Conversely, if a patient presents with those exact same four symptoms, but the timeline is entirely episodic, meaning they suffer sudden, terrifying attacks of wheezing and suffocation that eventually clear up, leaving their breathing totally normal for weeks or months, the underlying pathophysiology is completely different.
You are dealing with bronchial asthma. The architectural structure of the lung hasn't been permanently destroyed. Rather, the smooth muscle surrounding the airways is hyperreactive to environmental triggers.
And the sequence matters just as much as the frequency, right? Usually the cough is the early warning system. It's the body's attempt to clear the initial insult.
Yes. The dyspnea, the sensation of actively suffocating, develops much later in the disease process once enough alveolar tissue has been compromised.
But the lecture highlights a terrifying clinical exception where that sequence is completely reversed: pulmonary fibrosis.
The mechanics of pulmonary fibrosis completely invert the standard respiratory timeline. In a fibrotic lung, the delicate, highly elastic tissues of the alveoli are relentlessly attacked by chronic inflammation and replaced by rigid, heavy, unyielding scar tissue.
The lungs essentially turn to stiff leather.
Exactly. They lose all their elasticity.
So because the lungs physically cannot expand to pull in a sufficient tidal volume of air, the patient experiences profound dyspnea long before the airway inflammation produces enough irritation or mucus to trigger a cough.
Right. They are suffocating from structural restriction before they ever need to clear their throat.
That's horrifying. Which brings us to the mechanical reality of the cough itself. We tend to view a chronic cough as a mere nuisance, right? A symptom to be suppressed with medication so the patient can get some sleep.
But viewed through the lens of pure biomechanics, a severe cough is an act of sheer physical violence against the human anatomy.
It is a massive kinetic event. When a patient coughs, they are forcefully exhaling against a closed glottis before suddenly releasing it.
And that traps the air and causes the intrathoracic pressure, the pressure inside the chest cavity, to spike to astronomical levels. We're talking sometimes exceeding 300 millimeters of mercury.
Wow. So for an elderly patient or someone with underlying corticosteroid-induced osteoporosis, the sheer concussive force of their own respiratory muscles clamping down can physically snap their ribs.
And the collateral damage extends far beyond the skeletal system. That violent spike in pressure can tear the delicate pleural lining,
causing a pneumothorax.
Exactly. If the pleura tears, air escapes from the lung tissue and rushes into the negative pressure space of the chest cavity, causing the lung to instantly collapse. The pressure can also pop the microscopic alveolar air sacs or even force abdominal organs to herniate directly through weakened muscle walls.
But for the clinician standing at the bedside, that violent mechanical reflex serves a crucial diagnostic purpose. It acts as an internal dredge, bringing up physical evidence from the deepest, most inaccessible parts of the respiratory tract.
We are talking about the expectoration of sputum.
And this is where the diagnostic pathway gets incredibly specific, especially when dealing with suppurative lung syndrome.
Yes, suppurative lung syndrome is an umbrella classification for highly destructive necrotic diseases like a massive lung abscess or severe bronchiectasis.
In these conditions, the structural integrity of the lung has broken down, creating literal cavities that chronically pool with infectious pus.
The clinical hallmarks are unmistakable. Massive volumes of expectoration, often exceeding 200 cubic centimeters or a full cup of foul-smelling fluid every single day.
And a highly specific mechanical phenomenon known as postural variation. Let's break down the fluid dynamics of postural variation because this is a brilliant bedside deduction.
Let's do it.
I like to visualize a lung abscess as a rigid bowl sitting inside the lung tissue. Imagine a patient has a massive, cavernous abscess in the lower lobe of their right lung. If that patient is lying in bed on their right side, that abscess acts exactly like a bowl holding water. Gravity keeps the purulent fluid safely pooled at the bottom of the cavity. The fluid isn't irritating the major airways, so the patient might feel relatively stable.
But the moment that patient shifts in their sleep and rolls over onto their left side, the anatomical bowl is tipped upside down.
Boom.
Gravity immediately takes hold, and massive amounts of toxic, purulent fluid pour out of the right-sided abscess, flooding directly across the carina and into the main healthy airways.
Which instantly triggers a violent, uncontrollable, choking, coughing fit as the lungs desperately try to clear the flood. So, as a resident, you don't need a scan to locate the abscess.
No, you just look at the patient and ask, which side do you sleep on to avoid coughing?
And if they tell you, I absolutely cannot lie on my left side, I start choking immediately, you have instantly diagnosed that the heavy fluid reservoir is sitting in the right lung.
It is utilizing fundamental gravity as a high-precision diagnostic instrument. And once the patient produces that fluid, the clinician must visually analyze it. The lecture transitions into what is essentially a pathological color wheel.
The specific hue of the sputum is dictated by the precise chemical and biological breakdown of the lung tissue. For example, if the patient coughs up sputum that is deeply rusty in color, the diagnosis points squarely to lobar pneumonia.
And the physiology behind that color is fascinating.
Right. The lung tissue is so severely congested with inflammation that red blood cells are physically squeezed out of the capillaries and leak into the alveolar spaces.
And as those red blood cells sit in the airway and break down, the iron molecules inside their hemoglobin literally oxidize from exposure to the air.
The patient is expectorating biologically rusted iron.
Then you have red currant jelly sputum, which carries a much more grim prognosis. This thick, gelatinous, dark red presentation is a hallmark of bronchogenic carcinoma or lung cancer.
Because the tumor creates a sticky matrix of excess mucus.
Exactly. It continuously sheds necrotic cancer cells and causes a slow, seeping vascular bleed from the compromised tissue. It all binds together into a jelly-like mass.
And then the source material highlights an almost unbelievable presentation: chocolate or anchovy sauce sputum.
Oh, this one is wild.
This isn't originating from a primary lung infection at all. This indicates an amebic lung abscess. The amoeba typically infects the liver, causing severe hepatic necrosis.
But over time, that expanding liver abscess can literally eat its way upward, burning a hole straight through the diaphragm muscle and rupturing directly into the base of the right lung.
So the dark brown, chocolate-like color is actually liquefied, digested necrotic liver tissue that has bypassed the diaphragm and is being coughed out through the respiratory tract.
It is a striking demonstration of how aggressive a pathogen can be in eroding anatomical boundaries.
The lecture also points out caseous or cheesy sputum, which is the classic textbook manifestation of tuberculosis, representing the crumbly, cheese-like necrosis of the lung tissue.
And finally, frothy sputum, which looks exactly like bubbly white or pink soap suds.
And that requires immediate life-saving intervention. It's the defining sign of acute pulmonary edema, typically driven by acute left-sided heart failure.
Right. The left ventricle fails to pump, blood backs up into the pulmonary veins, and the extreme hydrostatic pressure forces watery blood plasma directly into the alveoli.
As the patient desperately hyperventilates, the turbulent air whips that watery fluid and surfactant into a thick froth that physically blocks oxygen transfer.
So the visual analysis of the sputum writes a massive part of the clinical story. But what happens when the fluid isn't altered by oxidation or mixed with mucus?
What if the patient is coughing up frank, bright red arterial blood?
That upgrades the clinical situation to hemoptysis. And the immediate responsibility of the physician when encountering hemoptysis is to differentiate the geographical source of the bleeding. Is it false hemoptysis or true hemoptysis?
False hemoptysis originates from the upper respiratory tract above the vocal cords, like a severe posterior epistaxis or nosebleed that silently drains down the back of the throat while the patient sleeps, pools in the larynx, and is subsequently coughed up.
But true hemoptysis originates from the lower respiratory tract, deep within the pulmonary architecture. And this is where the lecture dives into the incredible tactical warfare of tuberculosis.
This mechanism completely reframes how I view infectious diseases. Tuberculosis is a blood-borne pathogen, meaning it disseminates through the vascular system.
Yes.
Yet it notoriously prefers to establish its primary infection in the very top of the lung, the apex. From a physiological standpoint, that seems totally counterintuitive.
It really does.
Blood flow is highly gravity-dependent. The bases of the lungs get massive blood flow, while the apices at the top are relatively underperfused. If TB travels through the blood and needs nutrients, why does it colonize the driest, poorest perfused real estate in the chest?
It does so to intentionally evade the body's primary defense mechanisms. It is a masterpiece of evolutionary survival. Wow.
The human immune system relies on white blood cells, which are transported exclusively via the bloodstream. By anchoring itself in the apical region where the pulmonary blood flow is at its absolute weakest, the TB bacteria effectively builds a fortress in a biological blind spot.
So the immune system simply cannot deliver enough white blood cells to that specific area to mount a successful, full-scale eradication.
Furthermore, TB is an obligate aerobe. It thrives on high oxygen. The apex of the lung has the highest ratio of ventilation to perfusion in the body, so it gets maximum oxygen to fuel its growth, but minimal blood flow to protect it from the immune system.
But if it is hiding up in this relatively avascular attic, how does it end up causing these massive, life-threatening hemorrhagic coughing fits?
It is the relentless, destructive nature of the caseation process. As the TB bacteria slowly destroys the apical lung tissue, it hollows it out, leaving behind a necrotic void, an empty, dry cavity.
But that cavity is not static. No, the inflammation continues to consume the surrounding walls, causing the cave to expand outward millimeter by millimeter. Eventually, the expanding perimeter of that dry cave encounters and erodes directly through the wall of a neighboring high-pressure pulmonary artery.
And the moment that arterial wall gives way, it ruptures directly into the empty space.
Exactly. The lecture refers to this catastrophic event with a very specific Latin designation: bronchiectasis, sicca, hemorrhagica. It translates to a dry, non-suppurative cavity that, without any prior warning or mucus production, suddenly becomes a massive, high-pressure fountain of life-threatening arterial blood.
So we have covered the visible, tangible evidence, the biomechanics of the cough, the chemical composition of the sputum, the vascular erosion of hemoptysis. But the most terrifying symptom for the patient is the one you can't see.
Dyspnea.
Dyspnea, the sensation of suffocation. To understand the mechanics of breathlessness, we have to look at how localized lung damage triggers a massive systemic collapse. And that starts with understanding the VPD triad.
Lung function is not a single action. It operates like a highly coordinated three-step assembly line. V stands for ventilation, P stands for perfusion, and D stands for diffusion.
So if any single step on this continuous assembly line fails, the entire process halts, and the patient experiences acute dyspnea.
The diagnostician's mind must rapidly cycle through this triad to isolate the exact mechanical failure.
Let's trace that assembly line. Step 1 is ventilation. This is purely mechanical. It is the physical movement of raw, oxygenated air down the trachea through the bronchial tree and into the alveoli.
Right. So if a patient aspirates a foreign body, or if an asthmatic spasm clamps the main bronchi entirely shut, the physical pipe is obstructed. The air simply cannot enter the building. Ventilation fails.
If the air successfully reaches the alveoli, we move to step 2, perfusion. This requires the cardiovascular system to deliver deoxygenated blood to the capillary beds wrapping around those alveoli, ready to pick up the oxygen cargo.
Imagine a patient who has developed a massive pulmonary embolism, a large blood clot lodged in the pulmonary artery. The patient is inhaling perfectly fine, the airways are clear, and the alveoli are full of fresh oxygen.
But the vascular highway is blocked.
Exactly. The delivery truck never arrives to pick up the cargo. Perfusion fails.
And finally, step 3 is diffusion. This is the microscopic chemical transfer of oxygen molecules across the ultra-thin alveolar capillary membrane and into the red blood cells.
Even if the air is in the alveoli and the blood is flowing perfectly through the capillaries, the system can still crash.
Right, like if the lungs are filled with fluid.
Yes, like the frothy transudate of pulmonary edema or the dense pus of a lobar pneumonia. That fluid acts as an impenetrable barrier. The oxygen molecules simply cannot swim across that watery moat to reach the blood. Diffusion fails.
Identifying whether a patient is suffering from a ventilation, perfusion, or diffusion defect dictates your immediate intervention. But this physiological crash is often accompanied by intense physical suffering.
Which brings us to pleuritic chest pain.
And the lecture clarifies a physiological reality that often surprises junior trainees. The spongy parenchyma of the lung itself is entirely devoid of pain receptors.
It's a crazy concept. A patient can have a massive necrotic tumor growing deep inside the center of their lung, or a raging bacterial infection destroying the tissue, and they won't feel a single ounce of localized pain from the lung itself.
The somatic sensation of pain only registers when the destructive disease process breaches the outer surface of the lung and inflames the pleura.
The parietal pleura, the layer attached to the chest wall, is highly innervated by somatic pain fibers. When it becomes inflamed, it produces a sharp, localized, excruciating stabbing pain that intensifies dramatically with every inhalation as the inflamed pleural surfaces grind against each other.
Which perfectly explains a physical behavior that, on the surface, seems completely counterintuitive. Splinting. Like, if I severely sprain my right shoulder, I am going to sleep on my left side to protect it. But if a patient has severe, agonizing pleuritic pain on the right side of their chest, they will instinctively refuse to lie on their healthy left side.
They will insist on sleeping directly on top of the agonizingly painful right lung.
Why would they put all their weight on the injury?
It is a subconscious reflex of pure mechanical genius. By lying directly on the diseased, painful side of the thorax, the patient uses the sheer gravitational weight of their own body to pin that side of the rib cage against the mattress.
This mechanically restricts the expansion of the chest wall on that side, preventing the inflamed pleural layers from ringing together, thereby instantly minimizing the pain.
It's an internal gravitational cast. Yep. And even better, by crushing the sick lung under their body weight, they leave the healthy lung, which is facing up toward the ceiling, completely unencumbered.
The healthy lung can now fully expand and take over the heavy lifting of oxygenating the entire body. The central nervous system just intuitively understands the physics of chest expansion.
It is a profound survival adaptation. But we must understand that these adaptations have limits. A sick lung refuses to stay isolated. When the respiratory system begins to fail, it inevitably drags the cardiovascular system down with it.
And that catastrophic interconnectedness is best illustrated by a condition called cor pulmonale.
Cor pulmonale is the medical terminology for right-sided heart failure that is caused primarily by underlying chronic lung disease.
To understand how lungs can break a heart, we have to look at a microscopic reflex called hypoxic pulmonary vasoconstriction.
Right. So in a healthy, functioning individual, if a tiny, isolated section of the lung develops a mild pneumonia and stops exchanging oxygen, the blood vessels feeding that specific area detect the hypoxia.
They automatically clamp down.
They constrict. This localized vasoconstriction is a brilliant evolutionary design. It diverts the blood flow away from the broken, unventilated area, shunting it toward the healthy, oxygen-rich areas of the lung to maintain maximum efficiency.
It's like a traffic cop seeing a stalled car in the right lane and forcing all the traffic to merge into the left lane. It keeps things moving. But let's apply that localized reflex to a patient with severe end-stage COPD.
Their lungs aren't just damaged in one tiny spot. Their entire lung field is diseased. Every single alveolus is starved of oxygen.
And that is when this brilliant localized reflex goes catastrophically rogue. Because the hypoxia is global, every single blood vessel in the entire pulmonary vascular bed clamps down simultaneously.
The traffic cop just shut down every single lane on a massive 8-lane interstate.
The entire pulmonary highway is blocked. And the right ventricle of the heart is the heavy-duty tow truck whose only job is to continuously push venous blood onto that highway.
And suddenly, that right ventricle is forced to pump against a literal brick wall of extreme systemic vascular resistance. This is pulmonary hypertension.
The right ventricle is not anatomically designed for high-pressure work, is it?
Not at all. It is a low-pressure volume pump. As it strains against this massive resistance over months and years, the cardiac muscle hypertrophies, it thickens, it dilates, and ultimately it structurally fails. The right heart gives out.
And when the right heart fails, it creates a massive traffic jam that backs up into the systemic venous circulation, which perfectly answers a clinical question that might stump a first-year medical student.
Why would a chest patient even have swollen ankles in the first place?
Lower limb edema in a respiratory patient.
The lecture meticulously outlines 4 distinct pathophysiological mechanisms for why lung disease causes fluid to pool in the legs. The first, as we just established, is cor pulmonale.
The right heart fails. The venous blood cannot move forward, so it simply backs up. Hydrostatic pressure builds in the systemic veins, and gravity forces the fluid to pool in the lowest dependent part of the body, the feet and ankles.
But the second mechanism is entirely metabolic, hypoalbuminemia. We discussed earlier that patients with suppurative lung syndrome, like severe bronchiectasis, can cough up a massive cup of purulent sputum every single day.
That sputum is packed with proteins and immune cells. The patient is literally expectorating their blood's protein reserves.
Without sufficient albumin circulating in the bloodstream to maintain oncotic pressure, the water is no longer held inside the blood vessels. It freely leaks out of the veins and saturates the interstitial tissues of the legs.
The third cause is secondary renal damage. Severe, chronic, destructive lung infections force the immune system to release a constant, heavy stream of inflammatory proteins into the bloodstream over years.
Eventually, these misfolded proteins precipitate out of the blood and physically clog the delicate glomerular filtration system of the kidneys, a pathological condition called amyloidosis.
The damaged kidneys lose their ability to regulate fluid and protein balance, leading directly to profound systemic edema.
And the fourth cause is an invisible chemical cascade, an acid-based disturbance. When heavily damaged fibrotic or emphysematous lungs can no longer efficiently exhale carbon dioxide, that CO2 begins to accumulate in the bloodstream.
Dissolved CO2 forms carbonic acid, dropping the pH of the blood and creating a state of respiratory acidosis.
And human physiology will not tolerate an acidic environment. The kidneys immediately step in to compensate for the failing lungs. To buffer the acid and raise the pH back to normal, the kidneys begin aggressively reabsorbing and retaining bicarbonate and sodium.
But there is an unbreakable, fundamental rule of renal physiology. Wherever sodium goes, water must inevitably follow.
By aggressively retaining sodium to fix the blood's pH, the kidneys inadvertently force the body to retain massive volumes of water, swelling the patient's legs.
So the kidneys are desperately trying to fix a life-threatening acid problem caused by the lungs, and the unavoidable side effect is massive fluid retention.
The interconnectedness of these organ systems is staggering. And this systemic crash doesn't spare the hepatic system either. A severe chest patient can present to the emergency room with clinical jaundice, a deep yellowing of the skin, and the sclera of the eyes.
Which requires the clinician to rapidly determine the causality, because lung disease can trigger jaundice through entirely different mechanisms.
If a patient suffers a severe pulmonary infarct, where a large section of lung tissue dies due to a pulmonary embolism, the massive destruction of red blood cells trapped in that infarcted tissue releases huge amounts of unconjugated bilirubin into the blood.
The liver is overwhelmed, resulting in hemolytic jaundice.
But if the patient is suffering from bronchogenic carcinoma, that primary lung tumor can aggressively metastasize, sending cancer cells through the bloodstream basically to the liver.
Those metastatic tumors grow and physically compress the biliary tree, obstructing the flow of bile into the intestines. The bile backs up into the blood, causing severe obstructive jaundice.
So synthesizing all of this complex physiology, what does this actually mean for you, the resident stepping onto the hospital floor? It means that you do not start your physical exam by immediately placing your stethoscope on the patient's chest.
Section 3 of the clinical slide deck emphasizes the general exam. You must comprehensively read the entire systemic ecosystem before you ever listen to the lungs.
The lecture establishes a rigid foundational rule of 4 for this initial observation. Before touching the patient, you must assess their general condition, their mentality, their physical build, and their decubitus, which is their physical posture in the bed.
Let's analyze the vital signs in the physical build. You take the patient's blood pressure. If you are evaluating a chronic respiratory patient and their blood pressure is severely elevated, your immediate diagnostic thought should not default to primary essential hypertension or cardiac disease.
You must consider bronchial asthma. Why? Because severe chronic asthmatics are heavily treated with systemic corticosteroids.
These steroids induce potent mineralocorticoid effects, causing massive sodium and fluid retention, which drives the systemic blood pressure dangerously high. The hypertension is iatrogenic, caused by the respiratory treatment.
But on the completely opposite end of the spectrum, if you have a patient with a chronic wasting cough and their blood pressure is catastrophically low, say 80/50, you have to think about disseminated tuberculosis.
If the TB bacteria breaks out of the lung, enters the bloodstream, and travels to the adrenal glands, it can physically destroy the adrenal cortex.
This causes an absolute failure of cortisol and aldosterone production, known as Addison's disease. The lungs have triggered a massive endocrine failure that completely tanks the blood pressure.
Then you evaluate their overall physical build, looking for extremes. The clinical masterclass deeply contrasts Pickwickian syndrome with cachexia.
Pickwickian syndrome, or obesity hypoventilation syndrome, represents an extreme mechanical failure. The sheer, immense physical weight of the adipose tissue draped over the anterior chest wall and the heavy abdominal fat pressing upward against the diaphragm literally crushes the respiratory muscles.
The brain is sending the signal to breathe. The lungs themselves might be relatively healthy, but the diaphragm simply cannot generate enough negative pressure to lift that massive external physical weight.
They suffer from chronic hypoventilation solely due to the mechanical restriction of their own body mass.
Standing in stark contrast is cachexia, where the patient appears severely emaciated, essentially reduced to skin and bones, with profound muscle wasting.
This is a massive clinical red flag indicating a chronic, highly consuming illness, a malignant, aggressive lung cancer, or a rampant TB infection drastically alters the body's basal metabolic rate.
The disease process literally burns through the body's caloric intake and then aggressively consumes the patient's own fat stores and skeletal muscle for energy, digesting the patient from the inside out.
Once you've assessed their build, you analyze their decubitus, their posture. How are they positioning themselves to survive? If the patient absolutely refuses to lie flat on the examination table and insists on sitting bolt upright, leaning forward, propped up on their hands or pillows, they are exhibiting orthopnea.
They're utilizing gravity to pull their heavy abdominal organs downward, away from the chest cavity. This gives their exhausted, struggling diaphragm just a few more precious millimeters of downward excursion so they can pull in air.
And while observing their posture, you closely inspect their face and mouth to see if they are utilizing pursed lip breathing.
This is when the patient inhales deeply, but exhales forcefully with their lips tightly squeezed together, as if they're trying to blow out a very stubborn candle through a tiny straw.
This is perhaps one of my absolute favorite mechanical adaptations in all of human physiology. Why do they do this? Let's look at emphysema.
In severe emphysema, the structural elastic scaffolding that normally holds the small airways open is completely dissolved by inflammatory enzymes. The airways become incredibly floppy, like wet paper straws.
When the patient tries to exhale, the rising positive pressure inside their chest actually surrounds and crushes those floppy airways flat. The tubes collapse, trapping the toxic, stale air deep inside the lungs.
But by pursing their lips, the patient creates a severe, deliberate physical bottleneck right at the mouth. This tight bottleneck generates a high-pressure zone that reflects backward.
That back pressure travels all the way down the trachea, through the bronchi, and deep into the smallest bronchioles. This phenomenon is called autopeep, or positive end expiratory pressure.
And that back pressure acts as an invisible pneumatic stent. It creates just enough positive pressure inside the floppy tubes to counteract the crushing pressure from the outside, forcing those collapsing airways to remain patent just a fraction of a second longer.
That tiny window allows the trapped toxic carbon dioxide to finally escape. The human brain, without any conscious calculation, instinctively figures out the complex fluid dynamics required to stent open the airways and keep the body alive.
It is a profound, intrinsic survival mechanism. While inspecting the face, the Egyptian professor also imparts a highly practical, culturally nuanced trick for the general eye exam, optimizing the physical interaction on the ward.
The curtain trick.
The lecture highlights a common local habit where a doctor will simply instruct the patient, look up at the curtains.
While looking upward allows the doctor to easily pull the lower eyelid down to check the palpebral conjunctiva for severe pallor, a rapid indicator of anemia, the expert clarifies a massive blind spot in this habit.
The professor strictly emphasizes that looking up is only half the necessary exam. To properly and definitively check for the subtle early signs of jaundice, you must deliberately instruct the patient to look downward.
This exposes the superior sclera, the top portion of the white of the eye. Because the top of the eyeball is constantly shaded and covered by the upper eyelid, it receives far less exposure to sunlight, wind, and environmental irritants.
Therefore, the delicate yellow tint of early bilirubin accumulation is much more pristine and apparent there than on the exposed, often bloodshot lower sclera.
It's these tiny, mechanical, deeply observational details that separate a textbook reader from a master clinician. Moving down from the face to the extremities, we hit a massive diagnostic trap for residents: finger clubbing.
This is a profound structural deformity where the terminal phalanges, the tips of the fingers, swell significantly and the nails dome outward like a watch glass. If you tell the patient to place the backs of their fingernails together, they lose that little diamond-shaped window of light.
And the lecture establishes an unbreakable cardinal rule regarding this physical sign. Pure, unadulterated COPD, no matter how severe the emphysema, no matter how profound the chronic bronchitis, no matter how hypoxic the patient has been for decades, never causes finger clubbing.
Hypoxia alone is not the sole physiological trigger for the fibrovascular proliferation seen in clubbing.
So let's play this out. You are in the clinic. A patient who has had perfectly stable, documented COPD for 15 years comes in for a routine checkup. You look at their hands and suddenly their fingers are distinctly clubbed.
As a junior doctor, you do not just shrug your shoulders, assume their COPD is simply advancing, and send them home with a new inhaler.
If you make that assumption, you might send them home with a fatal, undiagnosed complication. If a patient with known COPD suddenly develops clubbing, you must immediately launch an aggressive clinical hunt for a secondary, highly destructive process.
You are specifically looking for the silent new development of bronchogenic carcinoma lung cancer, or the insidious onset of a severe suppurative lung syndrome, like a massive hidden abscess or bronchiectasis.
The sudden appearance of clubbing means the fundamental clinical picture has drastically and dangerously changed.
Also, while examining the hands, you have to acutely observe for tremors. Imagine it's 3 a.m. on the respiratory ward. Your patient is holding their hands out and their fingers are visibly shaking. Is this an expected medication side effect, or is the patient crashing into respiratory failure?
Differentiating the kinetic nature of that tremor is critical. If the tremor is fine, rapid, highly regular, and almost like a nervous vibration, it is extremely likely to be a benign iatrogenic side effect of their rescue inhalers, such as salbutamol.
These beta-2 agonist medications, while targeting the lungs, also inevitably stimulate the beta receptors in the peripheral skeletal muscle, causing a high-frequency, fine mechanical shake.
But if they hold their hands out with their wrists extended back like they are stopping traffic, and their hands are violently, coarsely, and irregularly flapping up and down like a bird desperately trying to take off, that is not a medication side effect. That is asterixis.
Asterixis is a catastrophic neurological sign indicating impending metabolic encephalopathy. It means the patient's lungs are failing so profoundly that they can no longer clear carbon dioxide.
The CO2 rapidly accumulates in the bloodstream, crosses the blood-brain barrier, alters the pH of the cerebrospinal fluid, and essentially acts as a toxic systemic anesthetic on the reticular activating system of the brain.
The brain momentarily loses complete motor control of the extensor muscles in the wrist, causing the hand to suddenly drop before the brain wakes up a fraction of a second later and jerks the hand back up.
It's not a tremor. It's a rapidly repeating loss of muscle tone. It means the patient is actively slipping into hypercapnic CO2 narcosis. Their brain is shutting down, and they require immediate life-saving ventilatory support.
It is the physical manifestation of toxic blood. So we have comprehensively read the entire systemic ecosystem. We've evaluated the eyes, the hands, the posture, the legs, and the vitals. Only now do we physically approach the chest itself.
Inspection, palpation, and percussion. We are utilizing physics to map the internal architecture and acoustics of the thorax.
Inspection begins by simply observing the resting shape and the dynamic movement of the rib cage. The physical shape of the chest is essentially a historical fossil record of the patient's respiratory disease.
Consider the classic barrel chest. In severe, prolonged COPD, the destruction of alveolar elasticity means the patient can never fully exhale. With every breath, a little more air is trapped.
Over decades, that massive, increasing volume of permanently trapped air physically pushes outward from the inside.
The relentless internal pressure forces the ribs, which normally slope downward at an angle, into a completely locked horizontal position. The chest remodeling becomes so severe that the anterior-posterior diameter, the depth from front to back, equals the transverse width. The chest becomes a perfect cylinder.
Then you observe structural skeletal deformities, like pectus excavatum, commonly known as a funnel chest. The sternum is deeply and sharply sunken inward toward the spine.
This isn't just a cosmetic issue for a plastic surgeon. That deep physical depression severely squishes the right ventricle of the heart and drastically restricts the physical volume the lungs have available to expand.
And the diametric opposite is pectus carinatum, the pigeon chest, where the sternum protrudes sharply and angularly outward like the rigid keel of a bird's breastbone.
The lecture notes this is frequently a historical structural scar from severe childhood distress. Conditions like brutal childhood asthma or severe vitamin D deficiency, like rickets, severely soften the growing bones.
The intense, desperate mechanical effort of the accessory respiratory muscles constantly pulling on that pliable rib cage actually pulls the bone structure outward, permanently warping it as it calcifies into adulthood.
When moving from static shape to dynamic movement, the clinician provides an elegant golden rule of asymmetry. If you are standing at the foot of the bed and you notice the patient's chest is totally asymmetrical, one side is visibly bulging outward while the other side is sunken or flat, how do you know which side actually contains the underlying pathology?
The clinical rule is beautifully simple and relies entirely on function. The healthy side is the moving side.
You instruct the patient to take a deep, forceful breath. If the visibly sunken side expands smoothly and dramatically, but the bulging, hyperinflated side remains totally stiff, rigid, and frozen in place, then the bulging side is the diseased organ.
It might be physically immobilized by a massive collection of pleural fluid, a giant tension pneumothorax, or a solid mass. Function always reveals the true structure.
And while inspecting the chest, your eyes must always scan down to the epigastrium, the upper abdomen, just below the xiphoid process of the sternum. If you are examining a respiratory patient and you see a distinct, heavy, rhythmic pulsation beating against the skin of their stomach, it is a terrifying visual sign.
Because that forceful heartbeat absolutely should not be visible or palpable in the abdominal cavity. What you are witnessing is the massively enlarged, hypertrophied right ventricle of the heart, the direct result of cor pulmonale.
The heart muscle has grown so incredibly thick and heavy from fighting years of pulmonary hypertension that it has physically dropped, pushing down through the central tendon of the diaphragm and beating directly into the abdominal space. You are diagnosing severe end-stage right heart failure just by looking at the patient's belly.
Moving smoothly from visual inspection to palpation, we transition from using our eyes to using our hands to gather tactile evidence of structural damage. And this physical mapping starts right at the very top by placing a finger into the suprasternal notch at the base of the neck to palpate the trachea.
You are feeling the physical position of the windpipe, specifically looking for rhythmic mechanical tugs. If you place your finger on the trachea and you feel it being sharply yanked downward in perfect identical sync with the patient's radial pulse, you have discovered Oliver's sign.
The aortic arch sits directly over the left main bronchus. If the aorta develops a massive ballooning aneurysm, every single time the left ventricle ejects blood, that massive aneurysm expands, physically smashes into the airway, and mechanically yanks the entire tracheobronchial tree downward with every heartbeat.
But what if you feel the trachea being yanked downward not with the pulse, but in perfect sync with the patient's breathing? This is known as the COPD tug.
Because the lungs are massively hyperinflated with trapped air, the diaphragm is permanently pushed down into a completely flat, rigid sheet.
When the patient desperately tries to inhale, that flattened diaphragm has absolutely no room to move downward into the abdomen. So instead, the forceful muscular contraction pulls the entire mediastinum, the central connective tissue of the chest, downward, dragging the trachea down with it on every single agonizing breath.
Next, we utilize a technique called tactile vocal fremitus, or TVF. This is an exercise in pure applied acoustic physics. You place the flat, ulnar edge of your hand firmly against the patient's back and instruct them to speak a low, resonant phrase.
In the Egyptian clinical setting, the phrase is arba arba, and in English clinical training, it's typically 99.
You are feeling for the mechanical, low-frequency vibration of their vocal cords, transmitting down through the lung parenchyma and striking the skin under your hand.
The foundational physics principle driving this exam is that dense, solid masses and localized liquids transmit sound waves significantly better, faster, and with much greater intensity than porous air does.
A healthy lung is essentially a massive, highly aerated sponge, so it naturally scatters and dampens the sound waves. The vibration against your hand feels faint and distant.
But if an underlying lung pathology increases the density of the tissue, making that vocal vibration buzz intensely and sharply against your palm, you must immediately apply the diagnostic framework of the 3 C's.
The 3 C's that dramatically increase tactile vocal fremitus. Number 1, consolidation. This is the hallmark of lobar pneumonia.
The normally spongy, air-filled alveoli become entirely engorged and completely filled with heavy, solid pus, white blood cells, and inflammatory exudate. This solid mass acts like an acoustic superhighway, transmitting the vibration of the vocal cords straight through the lung and directly into the chest wall.
Number 2, cavity. If a patient has a large, superficial, hollowed-out empty space in the lung, perhaps an old TB scar or an evacuated abscess, that rigid empty space acts as an internal echo chamber.
It amplifies the low-frequency vibration, much like blowing air over the open mouth of a glass jug.
And number 3, collapse with a patent bronchus. This is a highly specific mechanical scenario. The distal lung tissue has completely deflated and collapsed in on itself, forming a dense, solid, airless mass of tissue.
However, the main breathing tube, the bronchus leading to that collapsed mass, remains completely wide open and unobstructed. The sound waves travel freely down the open tube, violently smash into the highly compressed solid lung tissue, and vibrate powerfully against your examining hand.
While feeling the chest for these vibrations, the lecture provides an incredibly elegant, highly practical bedside tool for residents. Imagine you have your hand flat on the anterior chest wall, and you suddenly feel a distinct, buzzing mechanical vibration known as a thrill.
How do you definitively know if that buzzing under your palm is a respiratory wheeze originating from severely narrowed bronchial tubes or a cardiac thrill radiating from a blown, turbulent heart valve?
It's the ultimate tiebreaker, and it requires zero technology. You simply ask the patient to stop and hold their breath. That's it.
If they hold their breath and the buzzing vibration instantly vanishes, it was a respiratory wheeze. It strictly required the kinetic energy of moving airflow to exist.
But if they hold their breath, there is absolutely no air moving, yet the vibration continues to buzz violently against your hand. It is a cardiac thrill, driven entirely by the mechanical, hydraulic pumping of the heart muscle and the turbulent blood flow.
So simple, yet entirely definitive. Okay, we have looked at the shape, we have felt the vibrations. Now we turn the patient's thorax into an actual acoustic instrument. We move to percussion.
This is the drum solo of the physical exam. By placing your middle finger firmly and flatly against the intercostal space of the chest wall and striking it sharply and quickly with the middle finger of your dominant hand, you are sending sound waves deep into the chest to measure the underlying physical density of the tissue.
A healthy, normal lung yields a standard resonant note.
But if the lung is pathologically overinflated and trapped full of stale air, as seen in end-stage emphysema, the extreme air-to-tissue ratio drastically changes the pitch.
It sounds hyperresonant, a loud, booming, hollow sound, exactly like thumping your finger against a tightly stretched bass drum.
Conversely, if you tap over a totally solid mass, like a dense cancerous tumor or a heavily consolidated pneumonia, it sounds dull, a short, flat thud, like hitting a thick piece of raw meat.
And if there is a massive pleural effusion where gallons of inflammatory fluid have accumulated in the pleural space, completely compressing the lung away from the chest wall, the percussion note becomes stony dull.
It feels and sounds completely dead, exactly like tapping your knuckle against a solid brick wall. There is zero acoustic resonance.
You utilize these varying acoustic notes to physically map the borders of the internal organs without ever needing an X-ray. Let's return to the bare area of the heart we discussed during the anatomical blueprint.
Normally, percussing the 4th and 5th intercostal spaces on the left side produces a distinctly dull note because the solid mass, the heart muscle, is sitting right against the chest wall.
But if you percuss that exact anatomical spot and it suddenly sounds hyperresonant, hollow, and drum-like, you've instantly diagnosed severe respiratory hyperinflation.
The lungs have ballooned out so massively from trapped air that the leading edge of the left lung has physically pushed its way between the heart and the ribs, inserting a thick acoustic blanket of air that completely obliterates the normal cardiac dullness.
The lecture also highlights a highly specific diagnostic zone known as Traub's area. This is a semicircular anatomical space located over the lower left ribs, which directly covers the fundus of the stomach.
Normally, percussing over Traub's area yields a tympanic note, a very high-pitched, hollow musical echo generated by the natural gas bubble sitting inside the stomach. But Traub's area is surrounded by potential, highly dangerous pathology on all 4 sides.
It is exactly like using sonar mapping to detect underwater threats. If Traub's area loses its tympanic ring and becomes dull from the top edge pressing down, it means a massive pleural effusion is weighing down on the diaphragm.
If the dullness encroaches from the bottom edge pushing up, the patient has severe ascites, gallons of fluid pooling in the abdominal cavity.
If the dullness violently shifts in from the right side, the left lobe of the liver is massively engorged. And if the dullness creeps in from the far left, the spleen is massively enlarged.
You are accurately mapping the structural integrity of 4 completely different organ systems just by listening to the changing pitch of a hollow gas bubble.
Which brings us to the absolute crown jewel of the percussion exam, a technique that demonstrates total mastery of clinical physiology. tidal percussion. This technique is a masterclass in using the body's dynamic, moving mechanics to precisely locate an ambiguous lesion.
Okay, picture this clinical scenario. You are percussing your way down the right side of the patient's back. Tap, tap, resonant, tap, tap, resonant, tap, tap, and then suddenly, bam, the note turns completely solidly dull.
You have hit something incredibly dense, but here is the million-dollar diagnostic question. Did your finger just hit the top anatomical edge of a perfectly healthy, solid liver sitting exactly where it should right below the diaphragm? Or did you just discover a massive, dense lung tumor sitting right above the diaphragm?
To solve this critical dilemma, you keep your pleximeter finger firmly glued to that exact horizontal line where the sound changed from resonant to dull. You do not move your hand a single millimeter. Then, you instruct the patient to take the deepest breath possible and hold it.
Because when they inhale forcefully, the diaphragm violently contracts, flattening out and pushing downward deep into the abdominal cavity to make room for the massive expansion of the lungs.
Exactly. It is a mechanical engine pushing downwards. If that solid mass you percussed was simply the healthy liver, the contracting diaphragm physically shoves the liver downwards, away from your finger, and the expanding air-filled lung slides down into the space directly under your finger.
While the patient holds their breath, you tap that exact same spot again. If the note has now miraculously changed from dull to resonant and hollow, you know the mass moved down, it was the liver.
But if the patient takes that massive deep breath, holds it, you tap the exact same spot, and it is still completely stony dull. That means the dense mass did not move out of the way. It is structurally tethered to the chest cavity above the diaphragm.
You have just definitively diagnosed a fixed lung tumor, dense consolidation, or a massive pleural effusion.
And there is a third, even more fascinating and terrifying scenario that tidal percussion can reveal. What if the patient takes a deep breath and that line of dullness doesn't go down and it doesn't stay still, but it actually moves up higher into the chest cavity?
That means the diaphragm muscle is completely paralyzed. When the chest wall expands during inhalation, it creates a massive negative pressure vacuum inside the thorax.
A paralyzed, floppy, useless diaphragm just gets violently sucked upward into the chest cavity by that vacuum, dragging the heavy, solid liver up with it. You just extracted all of that high-level functional, anatomical, and neurological data with nothing more than 2 taps of your finger.
It is brilliant foundational medicine, so we have mapped the entire physical structure. Now, in Section 5, we finally reach the culmination of the physical exam. We put the stethoscope in our ears. Auscultation, decoding the complex fluid dynamic symphony of the airways.
The lecture mandates a rigid, sequential, 4-part blueprint for auscultation. As a clinician, you do not deviate from this algorithm. Step 1. Assess air entry. Is the air actually reaching the deepest bases of the lungs, or is the breath completely absent?
Step 2. Determine the character of the baseline breath sounds. Step 3. Listen for adventitious sounds, the pathological extra noises. Step 4. Evaluate vocal resonance.
Let's deeply analyze Step 2, the baseline character. A healthy, fully functioning lung produces what we call vesicular breathing. To truly understand why healthy breathing sounds the way it does, you have to view the vast spongy network of alveolar tissue as a highly efficient acoustic dampening filter.
I think of it exactly like a low-pass filter used in a professional audio engineering studio. When a volume of air rushes down the main trachea and into the primary bronchi, it is moving at high velocity. The flow is highly turbulent, loud, and incredibly harsh.
But as that column of air branches out into millions of tiny, increasingly microscopic airways, and finally into the spongy, air-filled alveoli, all of that healthy, porous tissue physically absorbs and dampens the harsh, high-frequency acoustic energy.
By the time the sound waves penetrate the chest wall and reach the diaphragm of your stethoscope, all the harshness has been filtered out. All you hear is a soft, low-pitched, breezy rustle like the wind gently moving through the leaves of a tree.
And the audible timing of that vesicular breathing is highly specific and mechanically revealing. The sound of inspiration is heard continuously for a much longer duration than the sound of expiration, typically presenting as a 3-to-1 audible ratio.
Now, this concept constantly trips up junior students, because obviously the sheer physical volume of air going into the lungs is exactly the same as the volume of air going out. So why on earth does the exhalation sound so much shorter and quieter?
We can perfectly explain this using the simple kinetic physics of inflating a rubber balloon. Expanding the lungs during inspiration is an active, demanding muscular effort.
The diaphragm contracts powerfully downwards, and the external intercostal muscles actively pull the ribs up and out. They're working hard to pull the air in against the natural elastic resistance of the lung tissue.
That sustained, high-energy muscular effort maintains a high velocity of airflow that creates enough acoustic turbulence for you to hear it clearly.
But expiration is a completely passive process. You just let go of the balloon's nozzle. The intrinsic rubber band-like elastic recoil of the healthy lung tissue simply snaps back to its original resting state, effortlessly squeezing the air back out.
Because it is entirely passive, the velocity of the exiting air rapidly decays. The airflow slows down so much toward the end of exhalation that it simply doesn't generate enough acoustic turbulence to be heard through the stethoscope. Hence the 3-to-1 audible ratio. The air is still moving, it's just completely silent.
But what happens when the small airways are severely diseased? This introduces the critical physiological concept of dynamic airway compression. Consider a patient suffering from severe asthma or chronic COPD. Their bronchial tubes are chronically inflamed, swollen, filled with mucus, and structurally narrowed.
When they actively inspire, the powerful negative vacuum pressure generated by the expanding chest wall naturally pulls outward on those diseased, narrowed tubes, opening them just enough to force the air in.
But the crisis occurs when they begin to exhale. The positive pressure required inside the chest to push the air out actually presses against the fragile outside walls of those already diseased tubes, crushing them even narrower.
The air immediately becomes trapped behind these collapsing strictures. The passive elastic recoil is no longer sufficient. The patient must forcefully recruit their abdominal and accessory muscles, actively squeezing and straining for a painfully prolonged period just to force the trapped air out through those crushed microscopic pinholes.
The audible ratio completely flips. Expiration becomes agonizingly prolonged, matching or even drastically exceeding the length of inspiration. It is the definitive acoustic hallmark of severe obstructive airway disease.
Okay, so that is the sound of vesicular breathing failing due to obstruction. But what if the spongy low-pass filter is completely destroyed and replaced? That gives us the terrifying sound of bronchial breathing deep in the lung periphery.
Bronchial breathing occurs when the spongy, air-filled alveoli become entirely engorged and solidified with dense pus and fluid, exactly as we see in severe lobar consolidation. The lung completely ceases to be an acoustic dampening filter and instead transforms into a highly conductive acoustic bridge.
It's just like putting your ear directly against a solid steel train track to hear a train miles away. The dense, heavily fluid-filled lung tissue takes that loud, harsh, violently turbulent noise originating from the central trachea and pipes it directly, totally unfiltered, straight to the chest wall.
It sounds incredibly harsh, high-pitched, and hollow, like someone aggressively blowing air through a hard plastic tube directly into your ear. Hearing bronchial breathing in the peripheral lung fields is always an indicator of severe underlying pathology.
But there is one highly specific geographical finding the lecture highlights that demands immediate attention: Dyspnea's sign.
If you're conducting your exam and you place your stethoscope directly over the patient's spine, specifically below the level of the T4 vertebrae, and you suddenly hear that incredibly loud, harsh, hollow bronchial breathing, you have identified a major structural emergency. There is absolutely no lung tissue or major airways directly over that part of the spine.
Dyspnea's sign means there are massively enlarged pathological mediastinal lymph nodes sitting right against the vertebral column.
These dense, swollen nodes act as a solid sound conductor, physically bridging the gap between the trachea and the spine, transmitting the harsh airway sounds straight into the bone. It is an instant, blaring red flag for severe diseases like lymphoma or rampant disseminated tuberculosis.
So we have established our baseline sounds. Step 3 is analyzing the adventitious sounds, the extra pathological instruments joining the respiratory symphony. We clinically divide these into continuous musical sounds, which we call raunchies or wheezes, and interrupted non-musical sounds, which we call crepitations or crackles.
Let's start with the musical wheezes. The physics generating this sound relies entirely on Bernoulli's principle of fluid dynamics. When a volume of air is forcefully squeezed through a pathologically narrowed, constricted tube, the velocity of that air must drastically skyrocket to maintain flow.
That extremely high-speed, high-pressure air rushing through the tight stricture causes the floppy walls of the airway to vibrate rapidly and musically, exactly like blowing hard across a clarinet reed.
We carefully classify these wheezes by their exact pitch to precisely determine the internal anatomy of the blockage. A sibilant wheeze is extremely high-pitched. It sounds like a sharp whistling tea kettle or a piccolo.
That high frequency tells you definitively that the air is squeezing through the absolute tiniest, most distal microscopic airways in the lung bases, the terminal bronchioles.
Conversely, a sonorous wheeze is deeply low-pitched. It sounds like a heavy rattling snore or a tuba. That lower frequency immediately tells you the obstruction is sitting much higher up, in the much larger central airways, like the main or lobar bronchi.
And as a clinician, you must also deeply assess the overall harmony of the wheeze. Is it a polyphonic wheeze or a monophonic wheeze?
A polyphonic wheeze is exactly what you hear during an acute exacerbation of COPD or a severe global asthma attack. Because the systemic disease inflames and constricts thousands of airways of all different sizes simultaneously across both lungs, you hear a chaotic, highly discordant chord.
You have high sibilant whistles from the tiny tubes violently overlapping with deep, low, sonorous groans from the large tubes. It is an entire chaotic orchestra of widespread airway damage.
But a monophonic wheeze is a single, solitary, unchanging, fixed pitch. It does not fluctuate. It is the terrifying sound of a rigid, localized, solid structural blockage. It tells you there is likely a single lung cancer tumor growing stubbornly inside one specific bronchial tube, acting as a fixed reed.
Then we move to the non-musical sounds, crepitations or crackles. This is the acoustic profile of sudden interrupted popping. My instinct, and I'm sure every intern's initial instinct, is that crackles always mean the lungs are wet, that air is simply bubbling violently through a pool of liquid.
And the Egyptian professor makes absolutely sure to disabuse his residents of that dangerous, overly simplistic assumption. Yes, wet, bubbling fluid like the watery transudate of pulmonary edema or the thick pus of pneumonia absolutely causes crackles as the inhaled air forcefully pops through the liquid barriers.
But there is an entirely dry structural mechanism that creates the exact same acoustic pop: interstitial fibrosis.
When the delicate, elastic lung tissue is destroyed and turns into rigid, stiff, unyielding scar tissue, those scarred alveolar walls act exactly like heavy-duty Velcro. During exhalation, they get completely stuck and glued closed.
When the patient forcefully inhales to draw a breath, the extreme negative pressure physically and violently rips those stiff scarred tissues open. That violent mechanical snapping of dry scar tissue sounds acoustically identical to a wet bubble popping.
The lecture provides a brilliant, culturally vivid analogy for understanding the sound of coarse crepitations, those loud, low-pitched, rumbling crackles originating from massive pools of fluid sloshing in the larger airways, typically seen in severe bronchiectasis.
The shisha analogy. Dr. Allam tells his students that severe, coarse crackles sound exactly like a loud, aggressively bubbling shisha or hookah water pipe being smoked across the room. It's such a visceral, undeniable audio image.
Once a resident hears that thick, heavy, low-frequency rumbling bubble at the bedside, they will never forget it.
But here's the ultimate challenge for the diagnostician at the bedside. If a wet fluid bubble and a dry fibrotic snap sound exactly the same, how do you differentiate between them? Or how do you know if that wheeze is from a glob of sticky mucus or a solid, immovable cancer tumor? The lecture provides the absolute ultimate bedside tiebreaker: the cough test.
You simply instruct the patient to give a strong, forceful, deep cough. The massive kinetic energy of that cough will physically propel and move liquid or mucus. If the patient coughs and the bubbling crackles completely clear up, or if the wheeze distinctly shifts to a different pitch, you are definitively dealing with mobile fluid or a shifting mucus plug.
But a cough, no matter how violent, cannot move permanent calcified scar tissue, and it certainly cannot dislodge a solid invading tumor. If the patient coughs and the crackle remains absolutely fixed in place, snapping with the exact same harsh rhythm, you've instantly diagnosed permanent structural fibrosis.
If the monophonic wheeze remains entirely unchanged in pitch or location after a violent cough, you are dealing with a fixed, rigid mass.
Okay, we have painstakingly built the entire mental slide deck. We understand the anatomy, the symptoms, the systemic failures, and the physical acoustics. Now, for Section 6, the capstone case study, we are going to integrate all of this complex physiology by walking through a real-world, deeply complicated clinical timeline. Because, as we are about to see, chronic disease expertly hides in plain sight. Meet our patient, Hamid.
Hamid is a 65-year-old Egyptian man. He spent his entire adult life working as a heavy laborer in a cotton ginning factory, meaning he spent decades chronically inhaling microscopic, highly inflammatory particulate cotton dust. Furthermore, his social history reveals he has smoked 30 heavily tarred cigarettes a day for 40 straight years.
Hamid presents to the emergency department in extreme distress, suffering from sudden, severe, terrifying dyspnea. He cannot breathe. But the seasoned professor immediately drills deep into the history, proving the cardinal rule that the timeline is the ultimate diagnosis.
Hamed didn't just get sick yesterday. He reports that 30 years ago, he developed a light, persistent morning cough, producing about half a cup of thick white sputum every single day.
Over the decades, that mild cough progressed to severe orthopnea. He now has to sleep completely propped up on 3 pillows just to breathe. And he developed a persistent, highly audible wheeze, cough, expectoration, dyspnea, wheezing. The classic diagnostic tetrad of COPD playing out over a 40-year timeline of relentless structural destruction.
But the clinician's notes contain 2 massive, deeply buried historical traps that would totally derail a junior resident who isn't thinking systemically. The first massive trap is his past medical history. Hamed contracted Bilharzia schistosomiasis, a parasitic flatworm infection highly endemic to the Nile Delta 35 years ago. It was treated aggressively with an old, highly toxic heavy metal injection called tartar emetic.
So the junior resident examines Hamed's abdomen and finds that his liver is massively enlarged, dropping well below the rib cage, and is exquisitely tender and painful to the touch. The resident looks at the chart and excitedly says, "Ah, I have solved it. He had Bilharzia. The parasitic eggs caused periportal fibrosis, and the toxic heavy metal injections further ruined the hepatic tissue. He has a cirrhotic liver from his past."
And the resident would be entirely dangerously wrong. A fibrotic cirrhotic liver resulting from an ancient parasitic infection and heavy metal toxicity would be shrunken, rock-hard, nodular, and largely painless. Hamed's liver is massively swollen, smoothly engorged, and highly painful.
Why? Because we must apply the physics of cor pulmonale. His destroyed lungs have caused massive, unyielding pulmonary hypertension. His right ventricle has completely failed against that pressure, and the venous blood has backed up like a severely blocked drain, intensely congesting and stretching the capsule of his liver.
The liver failure is actually heart failure, which is entirely driven by his lung failure.
The second clinical trap is surgical. Hamed had a severe, painful surgery for prolapsed hemorrhoids 15 years ago. A junior resident might completely ignore that as an annoying, unrelated gastrointestinal issue from his past.
But the master clinician connects the biomechanics. Think about the trauma of the cough. Hamed has been coughing violently, forcefully, every single day for 30 straight years.
That relentless, daily, extreme spike in downward intra-abdominal pressure physically forced the delicate venous plexuses in his rectum to severely engorge, weaken, and ultimately prolapse. The respiratory disease mechanically caused the surgical hemorrhoids.
It's all incredibly connected. Which brings us to the final medication mystery. A previous outpatient doctor saw Hamed's massively swollen legs, the severe lower limb edema from the backed-up venous fluid, and prescribed digitalis, a highly powerful heart failure medication. But the drug did absolutely nothing. His legs remained swollen. Why?
Because the doctor failed to understand the localized pharmacology. Digitalis is a potent positive inotrope specifically designed to increase the force of contraction of the left ventricle of the heart. But Hamed's left heart is perfectly healthy.
It is just sitting there, starved of blood, waiting for the right heart to push the volume through the lungs. His right heart is the one catastrophically failing against the brick wall of pulmonary hypertension. Giving digitalis to strengthen the left heart was completely physiologically useless.
So upon admission, the hospital gave him Lasix, a heavy-duty loop diuretic. It bypasses the heart entirely and forcefully forces the kidneys to excrete massive amounts of fluid as urine.
It literally drains the total volume of the venous traffic jam, drastically reducing the preload pressure on the right heart, allowing it to pump efficiently again, and finally relieving his engorged, painful liver and swollen legs.
It is a flawless, beautiful cascade of applied clinical deduction.
Yeah.
But before we finish this incredibly deep dive, the expert professor notes one final, utterly terrifying clinical reality that brings us full circle. We've spent an hour extensively classifying the loud, chaotic, turbulent noises of the diseased chest, the high-pitched wheezes, the rumbling crackles, the harsh hollow tubes.
But the absolute most terrifying sound you can ever encounter as a physician standing on the ward at 3 a.m. is no sound at all. The silent lung.
In a catastrophic, end-stage asthmatic spasm, or a massive tension pneumothorax where the lung fully and completely collapses. The smooth muscle of the airways clamps down so incredibly tight and the pressure becomes so immense that absolutely no air is moving at all.
There is no vesicular rustle, there are no adventitious wheezes or crackles, because there isn't even enough airflow velocity to vibrate the mucosal tissue. There is only a deadly, eerie, profound silence.
The complete absence of sound is the loudest, most critical alarm in all of medicine. It means imminent respiratory rest. So what does this all mean for you, the resident stepping onto the floor tomorrow morning?
If we connect all of this intense physiology to the bigger picture of modern medicine, we must acknowledge that we are living in a golden era of miraculous high-resolution technology. A multi-slice CT scan can map the exact three-dimensional volume of a lung tumor in mere milliseconds. AI algorithms can read and interpret chest X-rays faster and often more accurately than the human eye.
But a scan, no matter how high resolution, only shows you static broken parts. It is just a photograph of a collapsed building after the earthquake. This exhaustive, highly disciplined physical exam using nothing more than a stethoscope, your hands, and a deep understanding of physics reveals the living, breathing, struggling physiology in real time.
It reveals the invisible, life-saving auto-peep of a patient desperately pursing their lips. It reveals the intuitive mechanical genius of the splinting reflex. It maps the agonizing, unseen struggle of a right ventricle failing against a brick wall of pressure.
As AI, machine learning, and advanced diagnostic imaging become ubiquitous and heavily relied upon, it raises a profound existential question for the future of our profession. What happens to global healthcare if an entire generation of doctors forgets how to deduce a failing heart just by watching the subtle bulge of a neck vein on expiration?
Will our massive medical systems collapse under their own immense financial weight if we lose the fundamental zero-cost art of listening to the body with our own ears?
Imagine stepping up to a patient's hospital bed. You don't have an MRI machine. You don't have a CT scan. The power is out. It's just you, your stethoscope, and the echoes in the dark. Well, you know how to map the cave, something for you to deeply mull over until your next rotation.